Hello, my name is Brittany Gouse, and it is an honor to present our work on comorbidity burden among individuals living with a schizophrenia spectrum disorder. I am an assistant professor of psychiatry at BU School of Medicine, as well as a physician scientist and a psychiatrist in the Wellness and Recovery After Psychosis program at Boston Medical Center. The topic of this work is one that is very near and dear to my heart. Both my clinical and my research passion is in schizophrenia. In particular, an overarching career goal for me is to become a translational researcher who investigates strategies to reduce early excess death among individuals in the early psychosis period. I'd like to start by highlighting that the 13 to 15-year reduction in life expectancy in schizophrenia compared to the general population exceeds the reduction in life expectancy associated with many common lifestyle factors and health conditions in which there is a coordinated and nationwide effort to reduce the burden of these factors on life expectancy in the population. It is important to note that a substantial proportion of the number of excess deaths in schizophrenia is not due to psychiatric causes such as suicide, but rather physical disease such as cardiovascular disease and respiratory disease. This Finnish registrar study demonstrated that while the rates of death due to suicide has declined sharply among individuals living with schizophrenia, over the past 30 years, the rates of death due to cardiovascular disease and cancer have actually moderately increased. This particular finding is quite striking to me given the advancements that we've had in medicine over the past several decades. Taking a step back and thinking of the U.S. population as a whole, we know that there are notable disparities and inequities in access to preventive health care among individuals with low socioeconomic status. And we know that both individual and neighborhood level socioeconomic status impact health. Here I give two examples of structural barriers to living a healthy life that can affect the health of a whole community. Due to pervasive societal factors such as entrenched structural inequality, as well as discrimination in the U.S., individuals from racial and ethnic minority groups experience a disproportionate amount of socioeconomic disadvantage. This has a profound and a pervasive impact of health, and it is a major driver of health disparities in the U.S. Taken together in this work, I aim to explore the proportion of patients living with a schizophrenia spectrum disorder who have a severe physical comorbidity burden and are receiving care at an urban safety net hospital. We sought to undertake this exploratory analysis because, to the best of my knowledge, the Charleston Comorbidity Index has not been used in this patient population before. Further, we aim to compare the individual and neighborhood level sociodemographic characteristics between individuals with and without severe physical comorbidity burden living with schizophrenia. We hypothesize that belonging to a racial and ethnic minority group, as well as individuals living in a neighborhood with high socioeconomic disadvantage, will be associated with severe comorbidity burden in this population with schizophrenia. One of the reasons that presenting this work at this symposium is special as my KL2 support has allowed us to build the Access Initiative. Through Access, we have built a repository of several thousand patients with a schizophrenia spectrum disorder who have received care at Boston Medical Center. This data set was built in collaboration with BMC's Clinical Data Warehouse. Based off of prior work using the Charleston Comorbidity Index, we limited our sample to individuals 50 years of age or older. Additionally, our analytic sample was restricted to individuals with schizophrenia or schizoaffective disorder on their problem list. All sociodemographic factors included in the Access data set are extracted directly from our electronic medical record. This individual level data is connected to census tract level data to calculate our metric of neighborhood socioeconomic status. The SAS subscore of the Social Vulnerability Index was used as our metric of neighborhood level socioeconomic status. The SVI was originally created to identify populations that are highly vulnerable and would likely need a greater amount of resources in the event of a natural or human-made disaster. The SVI is calculated by connecting census tract to American Community Survey data metrics, which are listed here in this diagram. Of note, the SVI is a percentile ranking, so individual census tract vulnerability can be compared to the vulnerability of other census tracts in the state. The Charleston Comorbidity Index was used as our metric of physical comorbidity burden in this work. The CCI is a measure of both the number and the severity of medical conditions. The conditions included in the score are weighted by adjusted mortality. The Charleston Comorbidity Index score is used both as a predictor of mortality, as it was in the original study by Charleston et al. That looked at the risk of 1-year mortality among hospitalized patients. It can also be used as a metric of the degree of physical comorbidity burden, as we did in this work. In addition to descriptive statistics, I conducted a series of bivariate and multivariate analyses to explore the relationship between key demographic factors and severe physical comorbidity burden in this patient population, given the close connection between demographic factors and socioeconomic status that has been described in other populations. I utilize a correlation matrix to explore for the possibility of multicollinearity in this study. Further, to the best of my knowledge, CCI has not been used in this manner in a population of individuals living with schizophrenia. To this end, to gain insights regarding my methodology, I conducted a series of sensitivity analyses. Of the 1,739 patients that were included in the final analytic sample, 68% of the cohort had a CCI score of at least 1, and 12% of the population had a CCI score above 4, which met the threshold for severe physical comorbidity burden. Further, we found an association between race and ethnicity and degree of physical comorbidity burden. Here I highlight a greater proportion of both non-Hispanic Black individuals and Hispanic individuals met criteria for severe comorbidity burden compared to individuals from other racial and ethnic groups. We, however, did not find any association between neighborhood level socioeconomic status as defined by SVI and degree of physical comorbidity burden. In multivariate analyses, we found that non-Hispanic Black individuals had a 78% higher odds of meeting criteria for severe physical comorbidity burden compared to non-Hispanic white individuals. This was after controlling for other demographic factors such as age, sex assigned at birth, and neighborhood socioeconomic vulnerability. Our findings support that individuals with schizophrenia spectrum disorder face substantial burden due to physical illness. Additionally, and importantly, our findings suggest that non-Hispanic Black individuals with a schizophrenia spectrum disorder may have higher unmet healthcare needs, and this may translate to the higher severe comorbidity burden that we observed in this work. There are several limitations that suggest our findings should be interpreted with caution in its current form, particularly given our reliance on billing diagnosis as well as the single-center nature of our study. There is uncertainty around the proportion of individuals with a CCI of 0 that have missing data rather than a true lack of comorbidity. To this end, I look forward to investigating these study questions using data from the BMC HealthNet dataset, which will allow us to explore billing code use across multiple institutions. Thank you for the opportunity to present our work and for your time.